all of you interested in the next talk. So I think we all know that there's an antibiotic resistance crisis. That's kind of the theme for the morning session. A lot of what we think about in these talks start off with a strong, I should say, physiological background. When you talk about antibiotic resistance and using different types of antibiotics, the idea is that most antibiotics work through a different pathway. And we're going to discuss about synergy or additive effects. The idea is that you can try to act on two different pathways and see if there is an additive effect. Unfortunately, a lot of what translates at the bench doesn't translate to the bedside. So that's what we will see in the course of the next 20 minutes. So why did this concept of combination therapy come about? There is a very high incidence of resistant bacteria. We know from trials done maybe 15 years back where they found, particularly in ventilator-associated pneumonia, nosocomial infections, that appropriate initial therapy made a difference. If you didn't get the antibiotic right the first time around, your mortality was clearly higher. But it's very difficult for us to get our antibiotic first time around in an era where you have so much resistance. So if you look at these papers which came out on appropriate initial therapy, they came out in the early 90s. So since then, we've only got more resistance and less antibiotics. So that has been the main issue why combination therapy was proposed. There's also this concept of possibly a synergistic action. We know that aminoglycosides, we talked about PKPD last talk, not only the way they work, the way they're dosed, the way they work on the bacterial cell wall is completely different from penicillins or a beta-lactam, and possibly there could be some synergistic effect, especially when you have these resistant bugs and the patients are very sick. We also know that if you delay your appropriate therapy in septic shock, you have your increased mortality. And the hope is that if you combine 2 or 3 antibiotics, there's a higher likelihood that your first antibiotic is right. And the last one is a little controversial, possibly reduce the risk of developing resistance. And I was paying attention to Dr. Ram's talk. One of the things for resistance, combination therapy has not been mentioned. So combination therapy was thought to reduce resistance, but as you can see, that's not really been studied. What's the problem with combination therapy? Why not just give everybody combination therapy? One, you can increase drug resistance because you're going to expose these patients to antibiotics that they may not have been exposed to. 2, cost. The antibiotics that we combine are all going to be costly. And 3, a lot of studies have shown that combination therapy does increase your risk of toxicity. It's not a safe treatment unless you have strong evidence. So the rationale was that you broaden your coverage spectrum, and the clinical application is likely to be successful because your antibiotic, which is bactericidal, doesn't become a bacteriostatic drug, and to prevent the emergence of resistant strains. And this paper, which suggested this rationale for combination therapy, didn't come out now. This is a paper from 1983, long before we talked about ESBLs and NDM1s. So this is from the American Journal of Medicine in 1983, and this was probably before imipenem came about. So even then, people were worried about antibiotic resistance, and that's why, and talking about combination therapy. So there's a few concepts that we will just briefly talk about before we go into the data about combination therapy. The first one is, what is synergy? Synergy is what we want when we're combining 2 antibiotics. Synergy basically means that if you apply 2 antibiotics together, you produce an effect which is more potent than if both of these antibiotics were applied singly. And that's what we want when we're doing combination therapy. Additive effect is where the potency is roughly equal to the combination of the 2. So 1 plus 1 is 2. Synergy, you would want 1 plus 1 is 4. And antagonistic effect, which is what we don't want when we combine 2 antibiotics, is when the potency of the combination is less than the combined potency of each antibiotic. Now this is something we need to be very careful about. So just by combining antibiotics, we expect synergy, but you can have antagonism as well. So that's something we need to know before we combine 2 different classes of antibiotics. This concept of synergy is not something new. Right back in the 50s, they found that when patients who had enterococcal endocarditis, and you all know that penicillin was discovered only in the 40s, so when they combined penicillin with aminoglycosides, they found that the cure rates for patients with enterococcal endocarditis was much higher. So this concept was found way back in the 1950s. So the thought was that this boosted antimicrobial potency seems to help to clear your infection much more rapidly. The mechanisms of synergy could also be because of the way the antibiotics work on your cell membrane. Beta-lactams, for example, damage the bacterial cell membrane. Aminoglycosides inhibit protein synthesis. So what happens is, when your beta-lactams damage your cell wall, then these aminoglycosides can go in and then act on the cell and cause further cell damage. And that's the principle, at least, of synergy. So one of these effects is also called what we call as antibiotic resistance breakers, which enhance your antibiotic potency. So this is what you would see in a synergistic effect. When you have drug A and drug B, when you combine, the effect is much more than you would expect with just the isolated effects of A and B. Additive is just a 1+1 kind of scenario, and antagonistic is the effect is actually reduced when you combine these two antibiotics. So this was the physiological principle behind thinking about antibiotic combination therapy. Let's go to what the data is, and there's actually lots and lots of literature to go through. I'm not going to go through the small studies. I'll try to go through the more important papers. This was the first paper in probably in 2004 from Lancet. This was this was the meta-analysis looking at gram-negative bacteremia, not gram-positives. Here they found maybe a small difference, but there's only one study which showed any difference in mortality. Overall, there was no difference between combination therapy and monotherapy. However, there was a trend towards improvement in patients with Pseudomonas. Okay, and that's why if you go back to your ATS guidelines and your guidelines for Pseudomonas, combination therapy was recommended. Even now, if you go back and look, the idea is you always combine two antibiotics for Pseudomonas coverage. When that's based on this one paper, unfortunately, not too many other papers were able to substantiate that effect. And this is probably the main paper which most of you would have will be looking at. This paper came out in Critical Care Medicine in 2010, where they looked at a huge bunch of 4,600 patients of culture positive septic shock, where they looked at monotherapy versus combination therapy, and they found that there was a benefit in terms of a reduction of mortality. Now this is significant because they found a mortality benefit between with combination therapy. They also found a reduction in ventilator free days and pressor free days. So this was huge. So in 2010, this paper suggested that there was a significant benefit for combination therapy. And it didn't seem to make a difference what antibiotic you combined with what. So you combine beta-lactams with aminoglycosides, beta-lactam with a fluoroquinolone, vancomycin with an aminoglycoside. All of them seem to show maybe a trend towards improved mortality. However, what was interesting was the most potent beta-lactams, the 4th generation cephalosporins, and probably the carbapenems, didn't show much of a benefit. Now that's something to think about, and because a lot of times the idea of combination therapy is if you get your initial antibiotic wrong, but if your initial antibiotic is so broad spectrum that you are actually going to cover your bacteria, then you may not find a benefit, and that's what the study found. But this is a meta-analysis of studies done 10 years before 2010. So if you look, only 10% or 12% of patients got carbapenems. Now, if you have a patient with septic shock in your ICUs, or most of you will be working in a tertiary care center, and you have a patient with septic shock, you suspect a drug-resistant organism, how many of you are going to start with a broad-spectrum carbapenem? Probably a lot of you. So this is something to think about. Okay, so this paper, even in this study, even though they showed overall there was a benefit, when you looked at carbapenems, very broad spectrum antibiotics, there probably wasn't much of a benefit, maybe because these drugs were anyway bactericidal and they're likely to have a high sensitivity. So further studies were done looking at carbapenems combined with the fluoroquinolones and not or carbapenems combined with aminoglycosides, they didn't find much of a difference. There was a question, maybe you have decreased resistance, but they really couldn't find a difference. So this again suggests that if your initial antibiotic is pretty broad spectrum and has reasonably good cover, it is bactericidal, you may not find much of an effect. Now the other thing that people wanted to show was there a decreased resistance, but none of these studies were looking at resistance. This was a second endpoint or a third endpoint where they said maybe there was a decreased resistance, but none of the studies could prove that combination therapy actually reduced resistance. Now again, this was a meta-analysis done from this year, 2017. Here they had a randomized control trial of 2,633 patients. Here the difference was, unlike the previous analysis in 2010, where carbapenems were not that commonly used, here carbapenems were actually the most commonly used as monotherapy. They didn't find a mortality benefit. There was not a significant difference between monotherapy and combination therapy. And then if you go back to the Kumar paper in 2010, they found that the sickest patients had more benefit. The ones who got the combination antibiotic, that is, they got the second antibiotic early, seemed to have more benefit. So in this paper, they tried to split them up into two groups. The sick patients, Apache 2 scores less than 20, greater than 20, they still couldn't find a difference. Whatever analysis they did, they couldn't find a big difference between combination and monotherapy, irrespective of your disease severity. And again, this is a Cochrane review, which was done looking at about 69 trials with 7,600 patients. And again, they couldn't find a difference in combination versus monotherapy. So in fact, the conclusion was, don't add aminoglycosides to beta-lactams for sepsis because you may actually increase your nephrotoxicity. So side effects were increased, but there was no benefit. So why this difference? Why did the first few papers in 2004 and 10 suggest that there is a benefit, but the last few studies in the last 10 years not show a benefit? So the hypothesis of the initial paper was that the benefit will be restricted only to very sick patients with septic shock. The power of the study was enhanced because they split patients into septic shock and non-septic shock. And there is a structural bias because if you have patients who get less potent, if you look at the Kumar paper, many of the studies had patients who got first generation cephalosporins. They got clindamycin. The later papers, most intensivists were anyway giving beta-lactam, BL-BLI combinations, fourth generation cephalosporins and carbapenems. So there is a difference in the antibiotics that the patients received as the monotherapy. So the monotherapy which was done before is different from the monotherapy that we're giving now. Obviously the monotherapy right now is far more potent than what was given before. Again, this combination did not show any benefit between monotherapy versus combination therapy. Now, we all face a problem. This is for all septic patients, but we face a unique problem when we have multi-drug resistant pathogens. I think that's probably where we still tend to use combination therapy. So we have this MDR, Pseudomonas, and multi-drug resistant Acinetobacter. Is there a role in these kind of patients? Unfortunately, none of these meta-analyses were powered specifically for looking at these kind of patients. So you only have smaller trials looking at multi-drug resistant Acinetobacter or Pseudomonas. So in this study, they looked at colistin, combining tigecycline with colistin, or just colistin alone was monotherapy. Again, these are going to be much smaller trials because these are patients with a specific diagnosis, specific disease, specific bacteria, and who are multi-drug resistant. Again, here they found that maybe your microbiological and clinical success rates were higher, maybe a lower mortality, but this is obviously a very small data set. The other studies have looked at using double carbapenem therapies, combining two carbapenems for patients who have carbapenemase producing Klebsiella. Again, there may be a small benefit, but again, very small papers. Why are we getting these conflicting results? Well, the patient's characteristics are different. The very fact that you're now going to pick patients who have multi-drug resistant Pseudomonas or Acinetobacter most of these patients, it is a nosocomial infection. They're already sicker to start off with. They probably have been exposed to antibiotics before they got this bug. So your patient characteristics are going to be different. Their mortality may be very high, so it may not be powered to get a difference. Two, the site of infection may be different. They have different bacteria. You can't compare MDR Pseudomonas. We know that Pseudomonas in particular behaves very differently. Even in hospital, patients who get exposed to Pseudomonas get resistance as they get antibiotics in hospital. We've seen that. So you can't compare a patient with a Pseudomonas trial and a Acinetobacter and then extrapolate that data. So unfortunately, we're not going to have a lot of data for these kind of highly drug-resistant organisms. There have been some interesting concepts. This is a study which looked at ertapenem combined with meropenem. And the idea was ertapenem will basically take off your beta-lactamase, consumes your beta-lactamase, and allows your meropenem to work. So these are all interesting concepts, and they actually found that there was a microbiological success. But obviously, this is going to be an extremely costly sort of therapy. We are not going to get a huge mortality data in this kind of subset where it's very difficult to get a huge number of patients in this kind of study. So this was a recent paper, again looking at carbapenem resistant gram-negative bacteria, where they did not find a difference. Again, monotherapy versus combination therapy. This is not all bacteria. This is specifically carbapenem resistant gram-negatives. They didn't find a big difference. Looking at colistin or colistin rifampicin as a combination, they didn't find a big difference, even though smaller studies have shown some synergy when they use colistin or rifampicin or even sulbactam for Acinetobacter. So these synergistic studies do show some benefit in vitro, but as Dr. Ram was saying, in vivo, in the patient, there's a lot more other factors that come into play. So it's very difficult to predict how these patients are going to respond. They've actually looked at looking to see whether combining doripenem with colistin will reduce the rate of development of resistance. In vitro, it does seem to do it. But does that translate into clinical practice? We don't know for sure. This is a paper looking at Acinetobacter pneumonia. I put this up because this is a very specific diagnosis. It's a one organ pneumonia for nosocomial infection, Acinetobacter, and 90% of these patients had a ventilator-associated pneumonia. Here again, they found that 15 to 30 day mortality was higher in patients who had monotherapy. But so this is what most of the studies show, that if you have monotherapy and you have a multi-drug resistant organism, your mortality is higher, but combination therapy doesn't seem to reduce your mortality. That's going to be difficult to prove, again, because of the nature of the disease, the number of patients that we have. Maybe, like Dr. Ram was talking in the previous talk, we can't always look at mortality data in this subset of patients. Now, what about pneumococcal pneumonia? We still use combination therapy for CAP. For community-acquired pneumonia, if we see most guidelines recommend adding ceftriaxone and azithromycin or a macrolide or a fluoroquinolone. There is a difference, and it's not clear why. When you talk about pneumococcal bacteremia or community-acquired pneumonia, there does seem to be a difference. Even though in our country, rates of drug-resistant pneumococcus is not very high, the difference might be because most of these studies used azithromycin or a macrolide. And we know that macrolide have other properties. Macrolides have immunomodulating properties as well. So that might be the reason why in CAP, there still seems to be difference for combination therapy, whereas in the patients that we really need in nosocomial infections, we were unable to find a significant difference. So again, looking back at the evidence, the evidence is pretty small. There is really no data for double coverage of Pseudomonas, which is what was recommended based on the early trials. So double coverage for Pseudomonas is not recommended anymore. However, if you have a drug-resistant, multi-drug resistant Acinetobacter or a multi-drug resistant Klebsiella and a patient who's extremely sick, there still might be a role for combination therapy. It's very difficult to prove that there is a significant mortality benefit, but in these patients who are extremely sick, and very high risk of death, there may be still a role for combination therapy with two drugs, especially when the spectrum is very narrow. However, if you don't suspect resistance and you are going to give a monotherapy which is bactericidal and has a high or a very broad spectrum, there is really no role for monotherapy versus combination therapy. I'll stop there and take any questions.
Thank you, sir. And before going to the pro-con session, we'll have I invite some questions from all to the first three talks.
What is your take on combination with
Sir.
sulbactam, ribipine with azobactam?
Yes. So when we talk about combinations of two drugs like ceftriaxone and sulbactam which are being marketed, so I put those three pictures, the additive, synergy and antagonistic effect. So unless you have clear data that there is no antagonism and there is clearly synergy, because you're combining two different antibiotics, we don't know how they are going to react. I don't even think that when they did these combinations they have in vitro data, forget in vivo data. So I'm not sure, unless it's a tried and tested combination like a BL-BLI, like piperacillin and tazobactam. These are combinations which have been tried in patients as well. I have seen even combinations of vancomycin, ceftriaxone and sulbactam. I'm not sure that I would recommend, simply because we don't know what effect this is going to have. Is it going to be antagonistic? Is it going to be additive? Or if worse, antagonistic effect is even worse, and we don't know, and I don't think it has been studied. Also, when you look at the PK/PD, each one of these drugs has completely different PK/PD. So we try to ease out dosing and give it twice a day. How is it going to help when they have completely different PK/PD?
To comment on that, much of these arguments about synergy in vitro, much of this argument about synergy in vitro are based on pure pharmacodynamic, not necessarily PK/PD. It's very easy for us to extrapolate, because I don't think there are enough PK models of these combinations, these strange combinations, in terms of their drug levels, serum levels, etc. So I think it's all a bunch of extrapolations that we're really dealing with. I think we need to make that distinction. Whenever we say in vitro, it almost sounds like in vitro they did the entire PK/PD modeling, which is not necessarily very true. More often than not, it is only pharmacodynamics of how that bug reacts with the specific drug in vitro again.
My question is to Ramraj Kumar.
Wow, somebody listened.
Clinically, how do we imply this MIC levels unless we have the actual drug therapeutic levels available with us?
Yeah, that is the big problem. Okay, I have to admit that mine was a little bit high-flown in the sense that I was talking about ideal circumstances. I think there is a basic minimum requirement. When you talk about all those trials that show you that the response with PK/PD data is available, at least made an attempt at identifying drug levels at 2 points with a specific dose on a specific day, for instance. And that is a basic minimum requirement. That is a serious problem, because our when you ask for drug levels, it'll come, but a few days later. But it never does allow us to make real-time decisions. I agree with that. It becomes a problem. But at the same time, my argument is PK/PD as a concept has its value in the sense that other people can develop broad protocols and drug dosing patterns that can be extrapolatable. Otherwise, we are just using random kind of decisions about how we are dosing these medications. So that population studies that other people do under other settings can translate into benefit for us. But purely from your perspective and mine, this becomes a problem. A second and a serious problem that I didn't deal with is particularly when we throw in renal replacement therapies. Okay, and the way in which the efficacy of our renal replacement is so extremely variable that unless you measure levels, you're not going to be able to optimize it. So I have to be very clear about.
Why do we still run about and keep asking for MIC levels?
MIC levels, well, it's going to be the same thing. At least that's that's a belief that we want to minimize the misuse of the antibiotic, to minimize or to maximize the benefits. Yes, some answer on that.
One reason to check the MIC levels might be, again, this is theory is, if you give a high enough dose using these kind of principles, like a high dose of carbapenem, double the dose of carbapenem or double the dose of tetracycline, if you have a borderline MIC level, you combine two antibiotics, you can still get away. If there's a patient who has only one, is sensitive only to say polystin or resistant to everything. So those are the types of scenarios where an MIC level, if you find it is a borderline MIC level, maybe the theory is that if you can give a high enough dose of carbapenems, much higher than what we normally give, and even a drug like tetracycline, for example, a much higher dose. So those kind of situations, I think an MIC might be helpful.
One place where I traditionally will find it useful and it never is working is in the situation of, say, when you have meningitis, okay, and when you worry about the penetration and you'd like to know if it is highly resistant or not, it does change your antibiotic choices under those circumstances.
It's
So,
basically intermediate resistant.
yeah, you need to push it up a little bit. So some situations it can make a difference, but not on a routine kind of a basis. Okay.
In the same scenario, if we get an eye as a reporting, so in that scenario also we can just increase the dose rather than...
Not necessarily. I don't know whether it will always work. Okay, I'm not very sure about that. Okay. No, quite honestly, what we see with PKPD as it stands right now is it is a tool that is improving the way in which we are using our antibiotics, and hopefully it will come to a point where we will be able to model all this. In fact, the paper that I read was a translation from Italian, so it was written in a funny little language that I couldn't appreciate, but I did see that one of the points that they were working on was to look at models that involve renal replacement therapies. So it does, I'm pretty certain that it is going to be sophisticated. It is the same, you know, a few years ago, we used to be very worried about even lab tests like sodium and potassium that could vary from 0 to infinity on sequential tests. It's come to a point where it's become almost easy for us. We don't even look at it twice. Microbiology, standard cultures has come up to that level right now. Maybe the next step in the evolution of our monitoring techniques is going to be being able to get real-time drug levels and being able to interpret it. So I think it is more in the near future rather than something that we can ignore. But it raises a very important point, that is, we don't use antibiotics very well. And we better start using it well before it becomes archaic, before it becomes...
I just wanted to have a comment on that. MIC and the breakpoints. The breakpoints are decided by certain organizations.
NCLS. Yeah.
Certain organisms. So when you decide a breakpoint and decide an MIC, so may not be valid for a certain thing. So if your MIC is less than 2 milligram per deciliter for a certain, say, Pseudomonas, it's an arbitrary value. So when you look at the MIC, it tells you if it's your MIC 64, it's absolutely going to be useless to try that in any combination or even any therapy. But if the MIC is 4, you might get away with it. It's actually a sense of the concentration that you can try to achieve. And can you achieve that concentration by 2 grams 3 times a day rather than 1 gram 3 times a day? So a lot of things can be gleaned from more information is never harmful. So I would always look at it, and because you can glean more information.
I agree with you. Yeah.
That you cannot ignore that information that MIC is in real life is not useful. So please ask for the MIC and ask for whatever is the standard cutoff for that thing. The microbiologist will look up a book and tell you that the cutoff is about, say, 2 or 4 or 60 for that particular, and then look at the numbers and say, okay, this is 128. This doesn't seem to be working for a 2 milligram per deciliter. I think I need not even think about it. While if it's 2, I can think, okay, can I give 12, like, can I make the patient bankrupt like Apollo and Fortis by giving 15 grams of carbapenem? Sure.
I think you get away with the carbapenem because of the high safety therapeutic.
No, the breakpoints are changing. Be careful. He said look up a book. I hope they don't look up a book which will be 15 years old. But current guidelines keep changing. The standards for MIC keep changing based on PKPD models. So indirectly you're benefiting from that kind of an understanding. That's all.
I mean, it's not only PKPD models. Just recently, we are having problems with the Vitec not being able to give a good MIC level for colistin. And we are now changing over to the broad dilution method, where all the samples are going across for a broad dilution method, and we are finding that which has been reported as sensitive, when we go into a broad dilution method, we are finding that actually the MIC was probably in the resistant range rather than the sensitive range.
Good morning, sir. Good morning, sir. My doubt is whether colistin can be given in the nebulization pneumonia, whether we can avoid IBCOM in nephrotoxic patient.
So the question was, can colistin be given in the nebulization form? Yes, the answer is yes. It is been studied. But the data for colistin, there was lots of small studies, few patient, 2 patient, 3 patient studies on colistin as a nebulization therapy. Is there strong evidence? No. Is there very strong evidence? No. You also have to know how to give it by nebulization. It can cause bronchospasm, and when you make colistin for nebulization, it has to be, you can't prepare it, leave it outside and give it 6 hours later. So there are certain caveats to giving it as a nebulization. It can be given in a patient who is really sick with, say, a drug-resistant pneumonia where there's no other option left. Having said that, there's no strong data.
Can I start with the argument? There is no strong logic either. Okay, the traditional argument will be that if you gave it by nebulization, it will form a good layer across into the pneumonia and will not be absorbed into your system, so the benefits will be high and the toxicity will be low. These are very true if you take normal lung models which don't have pneumonias, where the deposition will be good and that absorption will be minimal. But if you take models in which there is pneumonia, the deposition into the pneumonic lung is extremely low. Where it actually matters, it is extremely low, number one. And additionally, because of the associated capillary leak, the serum levels are not significantly different from what you would expect when you give it parenterally. So there is a toxicity and there is a minimal efficacy. So if you look at the logic and then try to extrapolate it to application, there is no data to support its use on a routine basis. Additionally, you should know that when you're using nebulization, the way we do it is actually very uncontrolled. The best studies that show you how to give that nebulization tell you that there are so many parameters that you have to take. First of all, you can't, how do you nebulize your standard jet nebulizer? Useless way to do it. Ultrasonic nebulizers, useless way. You have to go ahead and get yourself an expensive vibrating drum of some kind, number one. Number two, you need to have very long inspiratory times. You need to actually sedate, paralyze, and increase the inspiratory time so that the deposition distally can be maximized. So there are a lot of issues related to nebulization that I would almost argue that you shouldn't even attempt to do it.
Sir, actually we are facing problem in the hospital getting capsular pneumonia that are susceptible to all the colistin, and patient with high creatinine or how is proceed for that patient?
Well, it got a ventilator-associated pneumonia susceptible to colistin. Give it parenterally.
High creatinine or can you give colistin full dose?
No. Can you give a normal dose? I didn't understand.
No, in high creatinine patient nephrotoxic.
Yeah, well, we go by whatever other people have derived about adjusting your colistin doses, and this just go by that, and I can't think of.
I want to make a comment on that. So when you asked about colistin as a nebulization, not as a monotherapy for this kind of patient. It will, when I say colistin nebulization along with parenteral colistin, it's along with parenteral colistin simply because for the factors that Dr. Ram said, we don't know exactly how much is getting deposited. We use a mesh nebulizer, but even with that, we don't know what kind of deposition happens in the lung. So you can't, to answer your question, can you use it as just nebulized therapy alone for a sick patient with a pneumonia? No. You have to give parenteral colistin.
Combination can be.
No, combination is 2 different antibiotics. You are giving the same antibiotic in 2 different routes.
Okay.
You are giving nebulized as well as in, but you can't give only nebulized and expect it to work, it will definitely not, because we don't know how it's going to work. If you give, you'll have to give parenteral colistin for sure. So creatinine or irrespective of the creatinine, whether you can add on nebulized colistin or not, you definitely have to give parenteral colistin.
Can I have the option of polymyxin B?
Which one?
Can I have the option of polymyxin B in this situation when I don't know how to adjust?
Yeah, and you worry about your renal clearance. Yes, you have an alternative. Absolutely.
Earlier this year, we have this Abdul-Ghafoor's paper on colistin's retrospective analysis of colistin monotherapy whereas multiple combinations. They said that monotherapy is as equivalent to combination. You don't need to go for the thing across the course.
Sure. That's most of what I said was basically the same thing. You are not in these kind of highly resistant subsets, Acinetobacter and multi-drug resistant Pseudomonas. The data, first of all, is very small. Two, it is going to be extremely difficult to find a big mortality benefit. So none of the, if you look at the data, it doesn't suggest a mortality benefit. There are papers which suggest that if you had colistin monotherapy, maybe your outcome was worse. But nothing suggests that if you take combination therapy, your outcome is going to be better. So it's like if you're anemic, you do worse, but transfusion doesn't make you better. So something similar kind of scenario. Having said that, so we don't have very strong data to support colistin as a combination therapy, but in the sickest of patients with high risk of death, and that's the situation where an MIC will be helpful because we face that all the time. We have borderline MICs to colistin. Yes. At least the MIC reported is borderline to colistin. Patient is on 3 pressors, young patient, high risk of death. Those are the patients probably we would consider combination therapy also. When you have a borderline MIC to colistin. In fact, those are the patients we typically ask for MICs on because you have somebody who's got only colistin sensitive and the MIC is borderline, it may definitely help.
Yeah, thank you, sir.